All righty, we are live with our Facebook and YouTube and weekly question and answer session. So this Q&A, if you have a dog with seizures or balance problems or difficulty walking or back pain or neck pain or wobbly walking or anything like that, if you're a veterinarian, if you're a vet student, this Q&A is for you. If you've got questions, leave them in the comments below and we'll do our best to get to them today. Southeast Veterinary Neurology is hiring. We opened a location in Jupiter a few months back, and we are looking for humble, hungry, smart, hard workers, people that are passionate about animals, people that are passionate about making lives better for people and their pets. So if you or someone you know gets fired up about that sort of thing, shoot us an email at HR, like human resources, HR at sevneurology.com. So that's SEV, like Southeast Veterinary, and then the whole word neurology, neurology.com. Or you can go to our website, sevneurology.com/careers. So I have Dr. Blake Webb with me today. Dr. Webb is one of the neurologists in our Boynton Beach office. And welcome, Dr. Webb. I guess tell me or tell everyone a little bit about yourself and what gets you fired up in the morning.
Sure. So I'm Blake Webb. I'm originally from Alabama. Did residency training after vet school in Wisconsin. So pursued some warmer weather here in Florida. Came to Seven right after residency. Moved here with my wife. We now have our little girl here. So have enjoyed being a part of the Seven team for over a year now. Things that get me fired up. I love coming into work and being able to work with an awesome team, helping pets walk again. It's always an amazing feeling. So, and getting to meet some really awesome clients down here is what gets me up in the morning.
Great. So I guess a couple things in general. We're somewhat limited in what we're able to answer. Just one from a client, patient, veterinarian relationship standpoint, just without being able to examine your pet in person. There's only so much that we can do, but the reality is without examining a pet, and that's kind of one of the questions that comes up here from one of the questions that we have today. Without being able to examine the pet, there's just not quite as much as we can do. So if you've got a neurologist in your area, if you have your local veterinarian, you know, a lot of what they're going to be able to recommend, they've got that luxury of seeing your pet in person. So, Emily, I don't see Chris on yet. You want me to jump to one of the other ones? Okay. So our first question is about seizures. It says, I know you guys see a lot of cases with seizures. How long does the post-ictal period typically last? In the post-ictal period, would dogs first become restless, then switch entirely to the opposite of being lethargic? Would love it if you could answer my question. Thanks. So just because it's kind of our first question, if you can talk a little bit about seizures in general, and, you know, just for people that don't know what post-ictal means, maybe give them a little bit of context there.
Yeah, for sure. So when we talk about seizures, so this is abnormal firing of the brain cells, and they fire all together. And so the outward signs that we'll see is what we call a seizure. So we can see loss of consciousness, lots of paddling behavior. You can see lots of salivation, urination, and defecation can happen during the events. And those would fit with more of what we call a generalized seizure, so kind of the whole body being affected. You can see some focal seizure activity, so sometimes they're not as violent or as clear. So sometimes patients can remain conscious. Sometimes you'll see kind of just focal twitches on one side of the face, some drooling, those sorts of things would be more classic. As far as you know, the phases of seizures, which I think the question was talking about post-ictal. So we have three big ones that we talked about in animals. So you can have a pre-ictal phase, so that means pre-seizure phase. So in the event leading up to the seizure, sometimes patients can feel a little funny. They may seek out their owners or seek out a quiet place, a closet, a bedroom, or something like that. In people, they talk about having an aura where they can sense that their seizure is coming on. We assume that maybe pets can do this, and obviously they can't talk to us, but that would be pre-ictal phase. The ictal phase is the seizure phase itself, so the actual, thrashing, paddling, those types of behaviors. And then afterwards, you get the post-ictal phase, so the post-seizure phase. And this can really vary patient to patient, and then also vary kind of on the situation. So some dogs, if they're having some focal facial seizures, they may be a little disoriented for a few seconds, a few minutes, and they go back right to being normal. For patients that have, generalized seizures where they actually do lose consciousness, sometimes there's a lot of heavy panting. They can be sedate or lethargic, or they could be opposite where they get up and they're pacing and they kind of have this compulsive behavior. Some patients can get into really bad emergency situations like a prolonged seizure or multiple seizures back to back. Sometimes they'll be way more sedate, and that post-ictal phase may last hours, days, depending on how severe. And also, patient to patient, what's causing their seizures. So sometimes if there's underlying brain disease, a post-ictal period could be pretty severe depending on what's going on and where they are in being managed for seizures. I don't think we can hear you, Dr. Wong. Just a heads up.
I'm getting there. Yeah, I don't have a whole lot to add. Just kind of my response, because we get that question a lot. And to me, every dog's different. I set people up more so not to say what to expect, that this is what their dog's going to do, but just every dog's different, and don't be alarmed. Some dogs act blind. Some dogs, they always want to be with you. Some dogs, they always just want to go outside. So every dog's different. So it's tough to answer, that question. Yes, it can happen where dogs become, restless and then become lethargic, or vice versa, where they're lethargic. So every dog's different. We're still waiting for the 1 o'clock to jump on in. So we've got the next question here. She says, I love your phenobarbital video, Dr. Webb. Related question. Syncope and seizures have similar signs. If a dog is diagnosed with a seizure and prescribed phenobarbital, but actually has syncope, and is going in and is going into congestive heart failure, would taking phenobarbital have any impact on its cardiac system? So I guess, to me, the questions there are talking about seizures versus syncope, how we tell the difference, and then, her specific question on, will there actually be a real downside or any downside to if the dog has syncope, but we're treating with phenobarbital?
Yeah, for sure. So syncope and seizures and even balance dysfunction disorders can be really hard sometimes to distinguish. But generally, some of the tall tale things that we'll look for syncopal episodes is where there's a lack of perfusion, the heart's not keeping up. Generally, these patients will have episodes of true collapse. They go limp, there's no paddling, there's generally no urination, defecation, foaming at the mouth. So we try to use those things to suss out, hey, this dog may have syncope over seizures. Also, a good physical exam, listening to that heart, listening for arrhythmias, those sorts of things can also help try to transition some of those patients into a syncopal category over seizures. We kind of talked about some of the things that we look for in true seizures. As far as, obviously we never want to give a patient a medication that they don't need. So if, we would try not to give phenobarbital to a dog that has syncopal episodes and not true seizures. Looking at videos, so like owners recording videos of the events they're seeing, can be really helpful for us to try to help distinguish that. As far as, long-term studies with phenobarb and heart failure in dogs, I'm not aware of any, but phenobarbital could cause, increased thirst, increased urination in dogs. You could theoretically change, how much blood volume they have. That would potentially not be good for a dog that would be going into congestive heart failure. So those are things that we would really want to look for on the physical exam to try to avoid. We generally will also do Xrays of the chest for most of our patients that we're fully working up. You would see evidence of congestive heart failure, and you would want to prioritize those types of treatments and make sure that we're on the right track for a patient.
Great, thanks. Kind of the one of the first questions we have here is from Maria. It says back pain, osteoarthritis. So I guess maybe if you can talk a little bit about just causes of back pain in general, and I guess how often it's truly arthritis versus other things that we see that cause back pain, and maybe the approach for back pain in dogs.
For sure. So there can be multiple causes of back pain. So, I mean, obviously the one that we focus on a lot is neurological causes of back pain. So infection or inflammation within the vertebral column, unfortunately, sometimes cancerous processes. And then what we deal with a lot of times would be disc herniations, disc ruptures that are putting pressure on the nerve root or their spinal cord and causing pain. There's orthopedic disease that could also cause back pain. You could have a true soft tissue injury like a muscle sprain or something like that could also cause back pain. Doing your physical and your neurological exam will kind of help separate out, does the dog have any neurological signs or not? And then as far as the approach to back pain, obviously examining that dog, trying to put them in one of those categories. If we do see true neurological components, reflex deficits or difficulty walking, we'll want to work that patient up, do baseline tests of blood work, making sure that we're overall healthy. You can do X-rays of the spine. It can pick up some things like spondylosis, which is a bridging of the backbones, some arthritic changes between some of the joints, but it's not going to be as specific as we want to try to pinpoint disc herniations or cancer or inflammation that has happened within the spinal cord itself. Sometimes it can pick up infection or cancer of a bone, which can be helpful and kind of get us on the right track sooner. But otherwise, advanced imaging, considering predominantly MRI for the spinal cord, sometimes CT scans, depending on what's happening, would pick up a lot of those diseases a lot faster and give you more information.
So I guess, can you say that one more time, just because I feel that's a common question for me, at least, of what can we see on X-rays? So I guess for the veterinarians out there, because some veterinarians, will now say to me, hey, I'm not even going to bother doing radiographs because I know you're not going to look at them. You're just going to do an MRI, which I guess to me is not the truth. There are things that I look for on radiographs. I guess, can you talk to them a little bit about, radiographs, what we can see, and then, like you said, some limitations of them?
Yeah, for sure. I mean, X-rays absolutely have a role in veterinary medicine, and we do look at X-rays that are sent to us. So the big things that you would want to do X-rays for is any kind of suspected trauma. So like things like dogs or cats that have been hit by a car or hit by something more than just a fall. X-rays will help show fractures and luxations of the spinal column, and those are really important to identify early because you want to make sure you treat those patients for that immediately and then keep them stable and transport them appropriately. You don't want them like trying to run around an exam room while you're looking at them. So it definitely has modality there. And then we talked about cancerous processes. So some older patients are going to be more prone to having cancer as a top differential. Things like multiple myeloma, osteosarcomas, and other types of sarcomas will show up on X-rays if they're involving bone, which they do. So that can be really helpful. Again, a cheap and easy way to try to find that and quicker for the patient. Other things that X-rays can be helpful for in young dogs with back pain, with fevers and high white cell counts, you can find discospondylitis, which is an actual infection of the disc end plates in between the backbones, common in younger kind of working breed dogs. And those are kind of diagnostic for the most part if you can see that in a young animal. So again, it can be really helpful and something that you can rely on. MRI is still going to give you more information. Is there, infection that has gotten into the spinal cord, like empyema, those sorts of things. You can look for more subtle lesions elsewhere, but the X-rays are helpful at picking up those diseases.
Awesome. Thanks. Emily, I saw that Hazel started to pop in. She's here, but then there she is. All right.
Hi, Bo.
Hi, Hazel. How are you?
Good. How are you guys doing?
Great. Thanks for jumping on here. I'm Dr. Wong. This is Dr. Webb. You've got a question?
Yeah, it's very nice to meet you both. First of all, thank you so much for taking the time to answer my question. I put in 2 questions in the email, but let's see if we have time to get through both. My first question is, if an old dog is presented with seizures, which component of the neurological exam is actually like the minimal steps or necessary steps? Why I'm asking this is because like seizure is already indicating a forebrain problem, and the blood test would rule out extracranial causes. And then if an old dog is supposed to go through MRI, CT, provided the anesthesia risk is not that high, then that will provide more accurate diagnosis on where the lesion is right. So how does the neurological exam sort of really add value as the middle step, and which component would actually be necessary?
Sure.
Yeah, so that's a really good question. So I always do a full neurological exam for the patient. And the reason being is you're absolutely right that a seizure does indicate a problem within the forebrain, the prosencephalon, but that doesn't mean that that patient can't have neurological dysfunction elsewhere. I actually had a case recently of a pet that had a seizure, and it was an older pet. We were worried about cancerous processes, but then we started noticing a lot of neurological deficits in the back legs as well. So your MRI is great at picking up exactly where in that brain the problem is, but it's only doing what you tell it to do. So we imaged the dog's brain, and yes, there was cancer there, but then imaging the dog's spine, there's also what we call drop metastasis. So cancer had spread down the spine as well. And you're not doing the dog a service if you're only looking at the brain, you're irradiating the brain, go into radiation therapy, and then you're missing this spinal component, spinal tumor component. So that's why doing that full neuro exam is always helpful. And building on that, the physical exam is always still very helpful, because sometimes you'll find enlarged lymph nodes and a patient may have lymphoma or something that has spread wide, and getting a sample of that lymph node is a lot faster and a lot cheaper to get the pet and the owner an answer, as opposed to doing an MRI and trying to find it through a spinal fluid tap. So it's important to cover all those bases. And then the last little part, you talked about running blood work to rule out the extracranial causes. Absolutely, we're looking for liver failure, kidney failure, and low blood sugars. Those are all super helpful, but it's not going to tell you if they got into a toxin or something like that. And in those cases, sometimes MRIs are normal. So history, physical exam, and neuro are all components that you have to do to help the patient the best that you can.
Yeah, I think the other 2 things for me to add there, just again, for me, yes, it's a full physical exam, full neurological exam. Just one, if I'm finding other abnormalities, and I guess this is very similar to what Dr. Webb said about finding a spinal problem, but it might change my list of differentials. So if I have a dog that just has seizures and let's say is just walking in circles to the left, so it suggests a left forebrain problem. I think of certain things like, solitary tumors, strokes, etc. But when I start seeing things that I can't explain just with one problem, with just one focal problem, so like a left forebrain problem, if I also have abnormal nystagmus or facial nerve paralysis, things like that I can't explain with just one localization, what we call multifocal, all of a sudden my list of differentials becomes different. I start thinking things like meningitis and encephalitis. I start thinking things like infections, multiple tumors, multiple strokes, things like that. And then to me, it's just also useful in interpreting the MRI. So now if you've done this MRI and you see something abnormal where you're not expecting it, from a dog with just seizures, let's say you also see something in the inner ear or the middle ear, if you haven't picked that up on your neuro exam, you're not going to know whether it's significant or not. One of the things that I've run into in the past is, just places that have an MRI and they'll MRI the dog kind of nose to tail, and they'll find these things that they'll find abnormalities, but it's very tough to interpret, well, is that significant or not? I've been on forums where people are talking about, their dog had an MRI of the brain and they saw, a slip disc in the neck, and now someone's calling them recommending surgery for the neck, but it's like, dog doesn't have neck pain. It's just, it's very much cart before the horse. So, you know, you're never going to go wrong by being too thorough. You know, I tend to be more upset at myself if I am like, I've been doing this a long time, I know what I'm doing, and that's the time. And I think every veterinarian, you know, will say that's the time I get burned is when I start, you know, getting overly confident. So I try and keep my mind very open, and you know, the saying, you know, the more you know, the less you realize that you know, or I'm sure there's a better way of saying it, but you know what I'm getting at.
Yeah, but that is a very great answer. Thank you so much. Like everyone says it's important, but no one really illustrate with real life examples. So that was like really insightful. Thank you so much, both.
Thanks. It's a great question.
Yeah, it was a really good question.
Yeah. Do we have time to quickly, if I could ask the second one as well?
Please.
That should be very quick. Thank you so much. So my understanding is if a dog has seizure and is in the post-ictal period, the neurological exam result is likely to be altered. So in that case, I understand that also from Dr. Webb's video about neurological exam, but I don't think it got to the point of explaining them when the neurological exam should be repeated. And if it needs to be repeated in a week's time, but you know, like anti-epileptic drugs is like maybe like prescribed before repeating the neurological exam, is there like extra steps that neurologics specialists need to make to ensure that the drugs is administered like that?
Yeah, for sure. So as far as, you know, an exact time as far as, for a dog that's post seizure, there's not a, you know, a hard fast answer of like exactly 1 hour later the dog, you know, will be normal. So it's hard because you'll have to know, you know, if it's an older patient, you worry about something may truly be going on in the brain, and so they may be post-ictal for a little bit longer. So I generally will do serial neurological evaluations. I mean, here it's a minimum of twice a day for anything that stays in the hospital, sometimes more frequently, but you'll basically repeat it over and over and see where things are trending. Are you picking up more deficits on one side of the body as opposed to the other? As far as paw placements, cranial nerve exam, and then that'll help you kind of piece together as that dog comes more and more alert. Is there something that we need to be aware of, or are they normal and maybe they just have epilepsy? But to me, it's more of a series of exams as opposed to the first one I can do, you know, right after a seizure. And it also kind of depends on, you know, how alert that patient will become. You know, some patients, if they have intracranial disease, they may be stuporous or comatose and have true like big changes in mentation. And in those cases, you're a little bit more limited, and you would do more of a like a Glasgow coma score, which, you know, you can find those online of checking baseline reflexes, gag reflexes, things like that. And I'll use that to kind of monitor them and watch for improvement before we get them up and do full neurological exams. So I guess the short answer is there's not a designated time, and, you know, I do more of a serial, you know, across the board, rechecking them multiple times, seeing where they've trended. It's always nice to have them come back in like a week or so. If they're doing well, repeat it, see where they are. And again, just knowing if they've had phenobarbital or bromide or something that may cause some paw placement deficits, you know, just having it in your mind and doing the best you can. But looking for the one-sidedness of exams in those patients is really helpful.
Yeah, definitely. I think the biggest thing is it being on your radar. You know, you knowing that, okay, this dog just had a seizure and I need to interpret with caution and need to examine again at some point is kind of the biggest take home for, you know, for me, for veterinarians and vet students. Just interpret with caution. I think Dr. Webb hit the nail on the head. If there's something that's, you know, it's dramatic, it's very lateralizing, that carries a lot more weight, but I don't have an exact time. It's very, very case dependent on when I'm looking again. You know, some dogs we're looking every, you know, 5-10 minutes, I guess for a different reason. But, you know, with regards to examining for, are these post-ictal changes, you know, to me, it depends on how many seizures we had, how severe it was. But to me, a lot of this is just, you know, a puzzle that we're putting together. So, you know, based on signalment history and how many seizures it's had, progression, etc., you might have a higher suspicion of an intracranial problem, and that might make you suspect that it's more likely to be a real finding. But again, serial examinations is the take home.
Yeah, that makes a lot of sense. So what I conclude is, just being very careful about the examination, trying our best to examine all the different parts that is possible to form the best diagnosis possible.
Yeah, and I mean, I can tell from the way you think about things, the way that you approach things, that you've got a lot going for you. I know it's not the answer that you want to hear, but a lot of it is just experience. The longer you do something and you've seen it over and over and over, you'll start to get that experience and kind of have a better idea of what's going on. I guess back to my point, I don't know if it was you or with someone else, but with experience also, you start to realize, well, gosh, even though I think it's this, it's not always this. And I'm throwing that in there just in case my next appointment says, I saw you on your webinar and you said you're experienced, so you should know what it is without doing an MRI or doing any tests. So I'm gonna cover myself there. Thanks for getting on, Hazel. Do you have any other questions?
No, that's it. Thank you so much, Dr. Webb. Really appreciate it. Very, very insightful response. Thank you so much.
Thanks for getting on here.
Very welcome. Thank you.
Talk soon. Yeah, thank you.
Those were great questions.
Mm-hmm.
So I've got one here from Rachel Ann. It says, my pup is 8 days post-op from IVDD. He was category 5, no deep pain perception. What are signs I should look for that he may be regaining feeling in his hind legs?
Yeah, so as far as monitoring at home, generally what I encourage owners to do is just to watch to see if there's any movement in the back legs. So if you're seeing movement, then pain perception theoretically should be coming back, with rare exceptions. What they'll do is, when you come back for your recheck exam with your veterinarian, they will recheck that by actually pinching on the toes, and sometimes we'll have to use hemostats for that and seeing if they can get a reaction. I don't recommend owners really doing that often at home because you can damage the skin and damage the toes. So for my purposes, I just tell the owners to watch if you're seeing movement in the back legs. These are encouraging signs, and you can call and let us know. But I leave the actual testing of that generally to the rechecks and with the doctors.
Yeah, so I guess for dogs that are category 5, so no deep pain perception, they're our most severe category. So they're not only unable to move their legs, but they're unable to feel them. And on a scale of 1 to 5, they're 5s. So like Dr. Webb said, kind of as things get better, they get better in the opposite order. So usually we regain feeling before we regain movement. And obviously we regain movement before we regain walking, and we regain walking before we regain coordination. I don't know if my hand's gone off the screen here. So I'm usually setting up owners, and I think that this is your question, Rachel Ann, is when should I expect any sort of improvement, and what should I be looking for? And I try and set up owners whenever I meet a dog that's category 5 to just be patient. It's not something that we do surgery and an hour later your dog is walking. When a pet is category 5 or no deep pain perception, there's only about a 50% chance of getting better, meaning walking, with surgery, and that can take months. I sort of give dogs about a month to regain feeling. Most neurologists that I know give actually a much shorter period, closer to 2 weeks, that if they've regained feeling in those if they haven't regained feeling in those 2 weeks, they're not going to. I've had a couple outliers that couldn't feel at 2 weeks and could at 4 weeks. So, now I tend to give a little bit longer. But, really right now, Rachel Ann, what I'd be focusing on isn't so much, is he moving his legs? Can he feel them? I'm pinching them every 2 hours to see if he can feel them. Really what you need to be focusing on is the other stuff that usually comes along with being a category 5, no deep pain IVDD dog. And to me, that's things like, the bladder management. That's things like the pain management. That's things like the down dog care, the crate rest. We'll usually crate rest after surgery at 8 days post-op. So I guess those are the things that I'd encourage you to be delving into and getting that information if you don't already have it. And like Dr. Webb said, kind of be patient and wait till you go back, for your dog's suture removal. I'm sure your neurologist or your surgeon will pinch your pup's toes then. And then if they can't feel them, usually I would see back in another 2 to 4 weeks to pinch one more time. I'm not sure if that answers your question. I guess the other thing, 8 days post-op, I guess I don't want to talk a whole lot about myelomalacia, but for me, myelomalacia can usually happen within the first 7 days post-op. Since you're day 8, I think it's unlikely. But myelomalacia, if you had said my dog is 5 days post-op, I'd be saying, wait, your cart's way before your horse. We need to make sure that myelomalacia isn't happening first. So, all right. Dr. Webb, Jeff asks, does idiopathic epilepsy shorten a dog's lifespan? Great question.
Yeah, that is a great question. So I think well-treated idiopathic epileptics that get their seizures under control and are managed generally don't have a decrease in their lifespan. They generally can do really well. But some things that could shorten their lifespan is if their epilepsy is not well managed, or sometimes they get really hard to control, they can get into life-threatening emergent situations. The 2 big ones would be what we call status epilepticus, or a prolonged seizure over 3 minutes, or cluster seizures, so more than like 3 in a 24-hour period. Those are things that could theoretically cause damage to other organs and to brain tissue. So those are things that could theoretically potentially limit lifespan if we're not getting those events out of the way and getting the seizures better controlled.
Yeah, I guess how often do you see, financial decisions, which often are related to the things that you said of not being as well controlled as we'd like? How often do you see that stuff affect lifespan?
You said as far as financial decisions?
Yes.
Yeah, so I've had a couple. There's predisposed breeds to developing epilepsy, and some of them are notoriously kind of hard to control. So I have had patients where we've had them on 5 or 6 daily medications. They have rescue therapies that are instituted anytime they have a seizure, and they can get very, very expensive. You're talking potentially a couple $100s every month on medications. And so I do see sometimes if these patients can't be well controlled, they are on lots of meds. Sometimes humane euthanasia can be something that needs to be considered as far as a financial means for owners and not being able to get improvement for that patient. So, that would be, something that I have seen and we've had to have those discussions before.
Yeah, and that's when people ask me this question, that's kind of my answer is I'm much more likely to lose the pet, not because of, because I think a lot of people worry their dog, they're going to go out to dinner, their dog is going to have a seizure, and then they're going to come home to a pet that's passed away. And while that can happen, I think I lose, let me make sure I'm saying this right. I lose a lot fewer patients to that than I do because either the ability to give medications, the costs of medications, the lifestyle changes, but then like you said, poorly controlled or status epilepticus. And, as a pet parent, I'm going into the emergency room every 2 weeks and spending a lot of money there. That's probably more frequently how I lose my patients.
Yeah.
Okay. Donna is here. And let's bring her on in. Hey, Donna, can you hear us all right?
I sure can. Can you hear me?
Perfectly. Thank you for getting on here with us and for being so patient. Donna jumped on. In Miami, we're not used to people being on time, and Donna is very, very early. So how are you today?
I'm doing well. I'm actually from Miami, but I moved to North Carolina 5 years ago.
Okay. What's going on with your pet?
My Akita is 4 years old now.
Okay.
Everything was fine. He was perfectly healthy. In March, we took him for his annual. When we took him for his annual, we had noticed that he was having trouble urinating, and we told the vet. And he said, okay, he looks like he's having a little bit. He said, looks like he's having a urinary tract, so he gave us antibiotics. The end of March, the antibiotics were gone. We didn't see an improvement, so we called him. And by then, COVID had hit. And he said, well, let me give him a stronger antibiotic. So he gave him a stronger antibiotic. Another 2 weeks went by, and there was no improvement. So we had to collect urine and take it in. And he said he was severe infection. So he gave him a different antibiotic. Well, then all of a sudden, the beginning of June, the dog almost passed because he couldn't urinate at all. And it came to find out he was misdiagnosed and there was a blockage. So we got shifted off to another vet, and they had to they couldn't clear the blockage. So they had to do surgery and reconstruct him. So now he essentially pees like a girl. That seems to be working. He's fine all there, but now he's seizures. Now we're on our third vet, and we can't get any help, and the dog is not getting any better. I've taken him off of everything except chicken, beef, or non-grain food. He gets no treats. I don't give him any table food as far as, anything left over.
No junk.
He gets no junk food. I give him plenty of water. We've taken him off of the they had him on Bravacta. They changed him to that. It begins with an SIM, flea medicine.
Syncope.
Well, I was reading on the box and it said it can cause seizures. So we're like, well, maybe that's the problem. Called the vet and we didn't get an answer. We had like 3 or 4 seizures in a day. We took him to aftercare. And they're like, well, maybe it could be the flea medicine. Take him off, put him on a collar. Well, then August came around and his pattern is like it was every 7 to 10 days. He seizures for 2 to 3 days. And then he'll go for 2 or 3 days. The last time, this past month, he went 10 days before he seizured. But the thing is, the seizures are not getting any better. All they will do is give us Keppra. And we're supposed to give him Keppra at onset of the seizure and 3 doses after, or until the seizures stop. And it's not helping. And we can't find another vet that's knowledgeable enough in the seizures. And most people don't have Akitas up here. So that's the second problem we have, is finding a vet that knows about the neurology of a dog and being able to treat an Akita. All of his blood work is perfectly normal. They think we're crazy. I actually had to videotape him going through a seizure and give it to the last vet just so we could prove it was an actual seizure.
They didn't believe us.
They thought, we were seeing something else until they saw the clip.
For sure. Unfortunately, it sounds like you guys have had a rough run. I'm really sorry to hear all of that. So, definitely there are some medications that we worry about that can precipitate seizures. There's been a lot of talks online about some of the flea and tick medications. The important thing to know is that most of those are very safe for most of the pets. There are some pets that can be sensitive, just like people can be sensitive to certain things. And I do try to use those medications as cautiously as possible for a dog that I know has seizures. But for your Akita specifically, it sounds like we're having recurrent seizures and we're having them kind of like in a cycle. So the concern would be that doesn't necessarily fit very well with a toxicity or with a monthly
Right.
flea or tick preventative. So you would start worrying about some other things. We still have big, intracranial causes, epilepsy, meningitis, congenital malformations. You worry about those things. If his blood work is overall normal and we're not getting repeated toxin exposure, it sounds like maybe his extracranial causes would be lower on the list. Obviously I can't tell you specifically without evaluating him, but for those patients where we're seeing seizure frequency this frequent, daily medications would be generally recommended, especially if the patient's having clusters. And then starting a rescue protocol for you as well for when there's more than one seizure in 24 hours would be, good recommendations. There are some neurologists. You said you're in North Carolina?
Yes.
There are some neurologists in North Carolina.
Do you have some that you work with?
I don't have any that I've worked with.
Do you have some that you? I'm sorry. You're saying that there are some up here that you know of?
Yeah, there's definitely neurologists there. I mean, the veterinary school at North Carolina, and I know that Raleigh and Charlotte, and there's at least one other major city that they have neurologists at their specialty centers there. So I think it would be, definitely prudent to reach out to any of those and see about getting an appointment. COVID has obviously made a lot of things hard for everyone right now. So wait times can be a bit, but I think that seeing a neurologist would be really helpful for your Akita and to get a plan in place. Keppra is a great drug, and it's one of kind of the 4 more common ones that we use, but every dog that has epilepsy doesn't have the same epilepsy. They may need a different drug. And so there may be some tinkering, no matter where you go, that needs to be performed, but finding the right cocktail is the ultimate goal of which drugs, your pet may need.
Donna, did you say that you're just giving the Keppra when your dog has a seizure, or are you giving the Keppra every single day? How?
Yes. Yes. We're supposed to be giving it to him on the onset of the seizure and then 3 to 4 doses after.
Okay. So if he had a seizure last month, are you still giving it today, or you're not giving it until he has his next seizure?
No. Right. We gave him on the first seizure, and then until we gave him the dose, and then every 8 hours until the seizures stop, which his cycle is probably like 3-ish days. And then after they stop, we stop giving him the Keppra.
Okay. So, again, this is, I don't know if you were here for the disclaimer at the beginning, where it's tough without me seeing in person, and I can't make actual recommendations, but in general, usually a drug like Keppra is what we call a maintenance medication, where it's something that we're giving on a more frequent basis. Yes, sometimes some neurologists will actually increase it or give an extra dose when a dog has seizures, but the goal of seizure management is to decrease the frequency, the number, and severity of seizures. So there's likely, I guess the take home would be, I wouldn't throw Keppra away as not working, but maybe we can, come up with a plan of how we're giving the Keppra. And most of the time, Keppra is a 3 times a day drug. Even if your dog didn't have a seizure that day, it still gets it on that day. Sometimes for dogs as big as Akitas, sometimes there's a formulation that we can use twice a day. But so I can't go saying, hey, change how you're giving the Keppra. I think it's worth, like Dr. Webb said, if you go to vetspecialists.com, there's a search function there, and you can search for a neurologist, in North Carolina, and it should list, most of them there. So and then I guess it's tough for me to say whether the seizures are related to your dog's urinary tract issues. Gut feel says probably not. There are certain conditions that sometimes we see them happening together, but I guess a 4-year-old Akita, the suspicion would be for something like idiopathic epilepsy based off of what you described. I guess
the last vet that we the last vet that we went to that gave us the Keppra, he was like, well, when a dog hits between 4 and 6, that's when seizures start. But he wouldn't really explain because, I mean, like I said, the dog was so healthy and he is a sweetheart. So it's kind of hard. He's as big as a horse, but he's, you know, he's like, he thinks he's a lap dog. And then when you see him go through these seizures, it's horrible.
Yep. Yeah. So seizures can start at any time, at any age. Age is important to us because we kind of factor that in because, you know, young dogs are more likely to get certain causes of seizures. 1 to 5 year old dogs is kind of the range I use, you know, are more likely to get certain other conditions. And then, you know, older dogs are more likely to get other conditions. So young dogs are more likely to have things like liver shunts or eat things they're not supposed to, get into toxins or get congenital birth defects, things like that. So if we have a 3-month-old dog with seizures, we're thinking of, you know, sort of this group of possible causes. I think what your veterinarian was saying is kind of, you know, 1 to 5, 2 to 6 year old dogs are when we most frequently see idiopathic epilepsy. So I suspect that's what your vet is getting at, which I agree, just based off of age and, you know, breed and being normal in between, has to be high on our worry list. But then with, you know, 8, 9, 10 year old dogs, we start thinking things like brain tumors and strokes and low blood sugar due to a type of cancer in the belly. So age is a factor, but we can't just, not all seizures start between 4 and 6 years of age. They can start at any time of age. I forget anything there, Dr. Webb? I feel like
No, I think you got it out.
Septic. He was so septic.
My husband is here too. And like I said, we've been to so many vets. It's been ridiculous. That's why we were thinking, because the one vet was like, oh yeah, it's because of that. Back from square one. Okay, what can we change? We put him on the strict diet. We took him off all of the medication. We made sure you know, we've done everything that we've read. We've watched all of your videos, trying to figure out what else it could be, you know, but yeah, definitely. I'll go online and see what I can find.
Yeah. I mean, seizures are,
because last month he had, what was it, 9?
No, 6.
Last month, this past cycle, he had 6 seizures in one day. Now they only last
a minute and a half.
Maybe less than a minute. The last one, maybe a minute and a half, no more than that. And he does bounce back. You know, in the very, very beginning when it was happening, he would be so out of it. It would take him 2 days just to recognize us. But now it's not like that. I mean, he comes right back. He does really well afterwards, but that couple days is horrible.
Yeah, I mean, seizures are something that we see relatively commonly, but you know, are things that you know, other veterinarians don't see quite as often. So you know, I guess a couple of things he said, you know, you're looking online, you're looking at our videos, so that's good. I like when people are trying to educate themselves, you know, by going online. Some sources of information are better than others, but when it comes down to it, having a veterinarian managing your pet seizures is going to, you know, be so much better and drive you less nutty. You know, if you go online, you're going to find so much. Some of it's good, some of it's bad, but you need someone managing it and kind of having an overall plan. So, so I'd talk with one of those veterinarians. You know, I'd ask them if they're comfortable or if they think, you know, it's time for you to meet with a neurologist in your area. Again, I don't know where in North Carolina you are and how close you are to a neurologist.
I'm close to Charlotte.
Okay. Well, great.
Thank you for your time.
You got it.
Very welcome.
No, you need to pay him the cost. I mean, that's the cost.
All righty. We've got a couple more here. I guess as we're on the seizure topic, if a dog comes with only one seizure, should we start medications? what medication, and this is assuming blood work was normal. So one seizure, start medications or not, and what medication would you start?
Sure. So generally, I don't start medications after a single seizure. Generally, if they've had 2 unprovoked seizures, meaning we know they didn't get into a toxin, we know they didn't have some other kind of metabolic issue, that's when I generally will consider working up and start seizure medications for a patient. Which drug to start is kind of dependent on a lot of different things: the patient, the underlying cause of the seizures, and also kind of, the owners or pet parents' scheduling. So a lot of our main drugs would be things like Keppra, phenobarbital, bromide, and zonisamide. And these are the drugs that we have kind of the most research on in animals and have better understanding of how to use and when to use. As far as which one, phenobarbital and potassium bromide are still kind of considered standalone, single agent drugs. So drugs that you can use on their own and have the most efficacy at stopping seizures by some of the consensus statements that have been, published out there in the literature. But some dogs may have kidney disease, or they may have liver disease, and so maybe we need to switch and consider something like Keppra that isn't metabolized by the liver. So you have to kind of take that as a case-by-case basis. Like Dr. Wong said earlier, Keppra is given 3 times a day, and some owners don't have a work schedule that would allow them to do that. So maybe that's not the right drug for that patient, or we need to do a different form of it, an extended release form of it. So the type of drug that's chosen is very client-patient situation dependent. But the phenobarb and the bromide are still very good drugs, even though they're the older ones, and they have lots of research to show that they work the best at stopping a lot of seizures.
Yeah, so that kind of goes on with another question that someone asked here of why not phenobarbital for the Akita that we were just talking to, and Dr. Webb just answered that phenobarbital would have been completely appropriate for that dog. We all kind of have our toolbox of drugs that we like to start with, and there are pros and cons of each one of them. So, but for the Akita, phenobarbital would have been a reasonable first line drug. I probably would have reached for Keppra as well for a 4-year-old Akita. Just big dogs like that, we end up having to give larger doses, or compared to a smaller dog, of phenobarbital. Being young, the effects on the liver, just long term. So I probably would have reached for Keppra or Keppra XR for this Akita, based on the information that I have. But phenobarbital would be completely appropriate if that owner said, from a cost standpoint, or from a 3 times a day, assuming that the extended release wasn't available for the Akita. So good question. Tim, I think it's going to be a tough question for us to answer, but you guys are on here every time, so I'll do my best to give you some love. So Tim asks, the Boykin Spaniel has been hit really hard with IVDD, somewhere around 20 since April. So within their group, most dogs are 3 to 6 years old. Do you have any thoughts on that number of one breed suffering from that disease in such a short period of time? So I guess thoughts on why we're all of a sudden seeing it more frequently in the breed.
Yeah, for sure. So I think we talked about it a little bit on the last Q&A that Dr. Wong and I did. So they have done some research now, and they have found some genes that are responsible for the intervertebral disc that sits in between the backbones to degenerate or age earlier in life than what you would expect them to. So in that 3 to 6 year range, similar to the more classic dogs like Dachshunds and Frenchies that we see have disc herniations. And so, with breeding and trying to keep lines, sometimes we can propagate these genes without knowing of their existence at the time. And so sometimes it becomes more of a prevalent problem within a breed, and as it is in Dachshunds and Frenchies already. And so that would be my suspicion as to why we're seeing this happen. But also there's environmental things. Boykins are also so high energy and like go dogs. They do lots of high impact activities. Sometimes they're working dogs, hunting dogs, things like that. So that can also put extra stress on those discs and cause them to have disc herniations. So those multifactorial kind of things would be what we deal with all of these breeds that have disc herniations.
I wonder if it's also a degree of just being aware of it. I don't know if Boykins have become more popular recently, or if now you guys you have this this forum and what social media is able to do, where people from all across the country are talking about it. So I wonder if it's just a degree of awareness. Once you start looking for it, you see it more often. But I don't think that's the whole factor, but I think that's, could be part of it. Emily asked me to answer Lauren's question. My dog was diagnosed with stage 1 cervical IVDD. He's been pain-free since day 2. What are your opinions for managing everyday life, things to avoid, prevent it from happening again? So stage 1 IVDD, cervical IVDD. So to me, that means the dog was just acting painful, was still able to walk, but either was crying out or holding its head low or having muscle spasms. So I guess, Dr. Webb, if you can talk specifically about that, but then just IVDD in general for, trying to prevent it for the future, what to be looking for, what sort of modifications we make.
For sure. So a lot of times we'll do kind of lifestyle management changes for these patients once we've suspected them to have had either a disc herniation, whether or not they've gone to surgery. So specifically for neck patients or neck pain patients, I will recommend no collars with a leash attached to it anymore. I'll recommend harnesses for those patients for the rest of their life to try and not put excessive pressure on their neck. They can wear their collar and have their tags, but to try and keep the leash off of their neck. Avoiding high impact types of activities can really be helpful as well. So big jumps off of furniture, running up and down stairs. We have some dogs that like to do the tug of war and shake their head and pull against those things. Trying to avoid that behavior is also helpful. For dogs that are in that kind of recovery phase, sometimes elevating their food bowl can be helpful, just to help putting or to keep strain from being placed on their neck. And so those are the kind of the big things that I talk to owners about. Mainly a lot of lifestyle changes and avoiding those high impact types of activities that we worry or hear frequently lead to a disc herniation.
Yeah. So like Dr. Webb said, intervertebral disc disease is lots of factors. It's not just one thing. But one of the big things is genetics, and we're not going to be able to change your dog's genetics. So that's where we try and manage it, just like he said. There's an interesting one here that I'll answer, more because it's interesting. It's not very common, so I hesitate a little bit in that I don't think a lot of people are going to see this. But can you talk about nerve sheath tumor, specifically one that was found in the elbow and not adjacent to the spinal cord? Front arm limping began in May, diagnosed in September, and was given about 3 months to live, or with amputation, maybe 10 months. 3 months later, symptoms haven't negatively progressed. Should I have considered amputation? So I'm not going to be able to answer specifically, should you have chosen amputation or whatnot. Most of the time, nerve sheath tumors, so taking a step back for everyone else, basically the nervous system is the brain, the spinal cord, and then the nerves that go out to the legs and to the organs and things like that. And we can have tumors of the brain, tumors of the spinal cord, but occasionally we'll get tumors of the nerves. And as neurologists, we mostly find them because they're up against the spinal cord. One, that's a common place for them to happen in the front leg. But two, it starts showing symptoms of rear limb weakness or front limb weakness. So it's relatively uncommon for us to find them further down the arm or the leg. And I don't know that it's necessarily because it's not as frequent, or just, those things cause lameness and we attribute it to things like arthritis or whatnot. And they're just a little bit harder to find, in that it's harder for us to MRI the entire arm as opposed to just the neck or just the back. I have seen 3 patients, not a huge number, where it was this lameness, and had seen an orthopedic doctor or a surgeon. The elbow's fine, the shoulder's fine, and we MRI, and we found what looked to be a nerve sheath tumor affecting the nerve distally. 2 of them have been kind of from the wrist down. One of them was from the ankle down. And all 3 of them that had surgery to just remove the nerve or the nerve sheath tumor, all did really well. Granted, all of those are real distal, real close to the toe, as opposed to close to the shoulder or the hip. So in doing that, most of the time, those are just sensory nerves, as opposed to ones that are needed to move the leg or ambulate or anything like that. So I believe, Dr. Webb, didn't we just cover something in Neurojournal Club where there was a dog but someone reported, I think it was a case series of 2 dogs where they were nerve sheath tumors in the elbow. So I guess, as a person that's never personally taken any of these out, but knowing surgeons that have, all 3, again, not a huge number, that were treated with just removing the actual tumor, did very well without having to have an amputation. Nerve sheath tumors in general tend to be really slow growing, and I lose them more when they're up near the spinal cord and they're pressing on the spinal cord, and then those dogs, stop walking. Whereas if it's further down the limb, it's more that the lameness just gets worse. So if you've got an MRI or your CT that's already diagnosed the nerve sheath tumor, I would ask your surgeon or neurologist to kind of, look into that one paper that I can't help you out with, but I think it was pretty darn recent, because we just covered it probably in the last 3 or 4 months. And look into that, in that my personal experience of N of 3 and this paper suggests that dogs can do quite well with distal nerve sheath tumors. It's 2:02. Let's do 2 more. Do you have time for 2 more questions, Dr. Webb?
Absolutely.
We've got one about sounds like vestibular and possible stroke, and one about an FCE. So that Emily's put here for me. So my 13-year-old terrier had a stroke 5 days ago. Her eyes have stopped darting around. So I assume 5 days ago we had abnormal nystagmus, and over the last 5 days that's improved. She can now walk a little, but won't drink water. She will eat. She seems to have forgotten how to drink water. Any ideas on how to work with this?
Yeah, so for dogs that have had strokes, it can take them some time to get back to normal. So the fact that you see slow and steady improvement is the norm for patients that have had strokes. They generally get very abnormal and then slowly kind of return back to normal. As far as helping with water intake, so sometimes these patients do need to kind of be like hand fed, have water brought to their face, and sometimes even syringing water or syringing food can be helpful depending on what their comfort is or their ability is. But also, making sure that there's not other neurological signs that are going on, because sometimes there's other nerves that can be affected that can change their ability to move their tongue, swallow, those sorts of things. So making sure that that has been assessed and looks good would be, what I would recommend for kind of at-home stuff.
Great. So going back to the nerve sheath tumor, yes, please reach out. Please reach out. And then the last question, where was the one about FCE? Melissa, my dog just came home last night from the hospital. She had an FCE last Monday. Does it take time for her to adjust being at home again? So to me, that question sounds like adjusting to being at home, but I guess if you can talk a little bit of, for people that don't know what an FCE is, and kind of how we diagnose it, and what the treatment and prognosis is for those. She's a pit bull and was in the hospital for 6 days. Sorry.
No worries. Yeah. So an FCE stands for a fibrocartilaginous embolism. So these are stroke-like events that happen to the spinal cord. We don't know exactly why these happen, but essentially we suspect a piece of disc material kind of breaks off and makes its way into the blood vessels that feed blood to the spinal cord. And when that little chunk lodges in the blood vessel, those neurons and those sections of the spinal cord don't get blood flow, and those sections of the spinal cord can die. And you can see very sudden and very dramatic neurological changes depending on where it happens in the spinal cord. So that's what an FCE is. Generally, you're going to need an MRI to diagnose that. CT scans generally can't pick it up. X-rays generally can't pick it up, but the MRI will be the most specific at finding that inflammation and those little areas of the spinal cord that have that lack of blood flow to show up bright on some of your sequences. So definitely an MRI diagnosis as far as I'm concerned. As far as adjusting for those patients, what do we expect? So these, like I said, are very dramatic. They can go from walking to paralyzed like almost immediately because of how quickly these neurons in the spinal cord can die. And this is also one of the diseases where we hope to see a slow and steady improvement over time. These are patients that I also think generally can benefit from some physical therapy down the road, depending on how quickly they recover. Some areas of the spinal cord, if they're affected by a FCE, could potentially carry a worse prognosis. So being further down in the spinal cord, sometimes they can get urinary or fecal incontinence, and those patients can have a rougher time getting back to normal as opposed to it being somewhere else. The recovery phase at home, very similar essentially to having dogs that have disc disease. So we want to keep them rested overall, make sure that they're on nice soft bedding, making sure they're eating and drinking. If they do have urinary or defecation accidents, keeping them clean is really important. As far as kind of transitioning back, I do hear sometimes dogs have a little bit of a difficulty going back home. Sometimes they're in a 24-hour facility. There's people coming in and out. They're awake way more than they normally are. So sometimes it takes them a moment to get back into their normal routine of, this is the time I go to the bathroom. This is when my owners go to bed and the lights go out. So sometimes it can take them a moment to get back into their normal routine, but generally they do that within a few days. I think that's hopefully answers all of that question there.
Awesome. Well, anything else, Emily?
I think there was one that we had on the Seizure Management.
Oh, yes, the very, very first one.
The last one.
The very last one you said. After spinal surgery due to so basically the question is, dog had surgery. How often do you like to do follow-up? Was operated in 2018 and he's doing great. I always think about this, especially when I see him playing so much with his big sibling. So I guess if you can answer what sort of follow-up we do in the short term for dogs that we operate on, and then I guess sort of the long term, how often you want to see them back.
Yeah, I guess if we're talking specifically disc herniations, I'm assuming.
Yeah.
So kind of, again, can be case dependent, but generally if I have a patient that comes in, goes through MRI and surgery for a disc herniation, they'll stay in hospital for a few days. The main goals that we want to see before they go home are eating and drinking on their own, either able to go to the bathroom on their own or easily expressed, and are comfy on pain medications. So walking isn't necessarily a check mark that they have to be doing to go home. So if a dog is walking, I generally want to see them back in about 2 or so weeks, and we'll get their sutures removed. And then generally I'll see them back at a 4-week from surgery mark. And during that time, they've been rested and in on crate rest. At that 4-week mark, I'll talk about adding back in some more activity and kind of assess of how soon do I need to see them back again. Potentially, if they're doing great, we'll push it out several months. If they still aren't where I want them to be, I might see them back again in another 4 weeks, or start them in physical rehab and then see them back in a few weeks. For dogs that go home and are not walking, I may see them back sooner, or if I'm worried about deep pain negative dogs, like I want to get them back in and check, are we getting sensation back? Those guys I like to keep a little closer and recheck sooner and potentially more frequently. Once my patients have kind of come out of the immediate post-surgery phase, we put them through increased activity and they're doing well. I don't necessarily need to see them very frequently. If they want to kind of establish baselines every 6 months, I'm fine with that. Sometimes just touching base on the phone, hey, everything's great, we're doing great, where are you out? Those sorts of things are fine at that point. I think more frequently, some of my patients, if they have another disc herniation or something, they come back, or have an episode of back pain, they come back sooner for those. But generally about 2 weeks for suture removal, recheck, 4 weeks for reintroduction to activity, and then it kind of varies for me from there.
Yeah. So for Oscar, who is coming up on his 2-year anniversary, no need to be calling for a recheck appointment as long as he's doing great. So I'm very, very similar. We're usually seeing back in around 2 weeks for suture removal, and we've probably called you 2 or 3 times in those 2 weeks to check in and see how things are going. Depending on how things are going at that, sometimes I see one more time, as long as things are going, the way that we want them to be. And, most people probably get 3 or 4 phone calls from us over the next year, just checking in to see how things are going. But at 2 years, if Oscar's running around like a maniac, no need for a recheck appointment at this point. Awesome. Well, thank you for getting on with us today, Dr. Webb. I think we answered a lot of questions and hopefully helped a lot of people that are, looking for some answers. So thanks, everyone.